today, warriors, you are in for a treat because Dr. Norman Kim is here to talk about anxiety, fear, and this concept known as exposure and response prevention. Dr. Norman Kim is an expert in anxiety and eating disorders and is also the National Director and co-founder of Reasonsedc Eating Disorder Treatment Center. Now, this idea around anxiety is huge, and for many people has led to aha moments about their recovery. And I am really excited for you all to connect with Dr. Norman Kim on this very important subject matter. So without further ado, Dr. Norman Kim, thank you so much for being with us here today at Recover Strong.
Oh, thank you so much for having me. It's a pleasure.
Always a pleasure to interview you. I know the podcast that you did on another way to look at eating disorders was one of our most popular ones to date. And what was kind of the main gist of that? Like, what is another way to look at eating disorders?
Well, I think sometimes we get so stuck on the diagnoses and like what makes it officially an eating disorder versus something else. And it makes sense, right? It's from our standpoint as providers, we need to think that way for reimbursement, for insurance companies, for authorizations, but also really from a clinical standpoint to be able to think about how someone's presenting, and so that we can figure out what the best way to treat them is going to be. For the person who's really struggling, it makes sense because you want to be able to have a handle on what's going on with you. But I think it's also really limiting because we're sort of pretending in a way that these really complicated illnesses and these really complicated psychological entities are sort of clear cut or they're categorical, and they're really not. Everything is really much more what we would call dimensional by nature, and I think by trying to simplify it for the sake of utility, you miss out on the complexity, which is really important, especially for what I do in higher levels of care. When someone needs 24-hour care, the complexity is really the main thing that we need to be concerned with, and the main thing we really have to look at and understand.
I think that's great that you guys have that multi-dimensional approach and it's not so linear and focused. Because you can miss out, right, on getting to deeper aspects of healing and treatment. Well, you've prepared a really informational presentation for us, and I'd love to get into that on this idea around exposure and response prevention. It could be a new term that people are hearing, and it's very interesting in eating disorders how this ties in.
Okay, so I think it's important to have. It's important for everybody. It's important for our treatment providers, but also if you're the person who's struggling, to have a way to understand what's happening and have a framework to understand what's happening. So what I'm going to be talking about is what's called a transdiagnostic view of eating disorders, which is just a fancy way of saying kind of what you and I were just talking about. How do we look at eating disorders in the broadest possible way, but in a way that's also still helpful and not without getting too bogged down in the details. And I think once you start thinking about it in a more big picture kind of way, then an approach like exposure and response prevention, which I'll be talking about, makes a lot of sense as a way to approach any level of treatment and any kind of treatment. This is something that most of us in the field do naturally. Anybody who's had experience with eating disorder treatment knows that a big part of eating disorder treatment is exposures of various kinds. So it's not like I'm saying anything particularly new, but what I'm hoping to do is to put it into some sort of framework so that people can understand a little bit better what all of that means. Why do we use exposure-based approaches? Specifically, why do we use exposure and response prevention in our program? And how can that be helpful for someone who's struggling? So when we look at the core characteristics of eating disorders, understanding that eating disorders involve what on the surface seem like pretty universal concerns, they're still quite rare, and they've remained rare, even though there's this proliferation of social media and even before social media, magazines and TV and everything, mass media, so much more emphasis on certain kinds of bodies and certainly a direct emphasis on being thin and all of that. So even though all of that is certainly amped up in the last 20, 30, 40 years, we're not seeing huge increases in rates of eating disorders, because that's not really directly what eating disorders are about, nor are those things that directly cause eating disorders. I think that's a very common misconception. But what we do understand about the core characteristics of eating disorders suggests that there's a common underlying factors underlying the illness that go across eating disorder diagnoses. It's among the most homogeneous of all psychiatric conditions, meaning the way that it presents tends to be fairly consistent. And anytime you have something this complex that presents in a pretty consistent way, that tells us something important about the nature of the illness, when it's not super variable in its presentation.
When you say that it presents the same, is that homogeneous even across all subtypes, like anorexia, bulimia, binge eating? And
yeah, we're gonna compare anorexia and bulimia more directly in a little bit, but yeah, even obviously there are the differences that determine whether you have one diagnosis or the other. So clearly there are differences that we use, but at their core, I think they always involve really the same things. They all and that has everything to do with sort of the bigger topic here, which is anxiety. At their core, there's this anxiety. At their core, there is this. There is a long history of difficulties with self-esteem and self-worth, and really profound insecurity that go across all eating disorder diagnoses. I think one way to think about it, or one way to look at it, would be asking yourself the question of what's the difference between an eating disorder and just dieting behavior. And again, this is one of those things that I think a lot of people really tend to conflate, especially in mass media, tend to conflate and sort of say that they're really one and the same. But if you think about the general population and how big the dieting industry is and how ubiquitous dieting behavior is, how many of us, more globally, not just a smaller group of people, but if you think about a larger population, how many people have ever been on a diet? That's going to be a huge number. But how many people have ever been on a diet and really loved it? That's a much, much smaller number of people who really, truly love being on a diet. How many people have ever been on a diet and loved it so that you picked it you picked it over being with friends and your family? You picked it over, being able to do your best in school or other kinds of relationships. Pick it over those things that give our lives meaning, like sports and music, art, going to parties with your friends. That's the difference between eating disorder and dieting behavior. Dieting behavior is just kind of is something that many, many people have experience with. But an eating disorder, when that kind of behavior might turn into an eating disorder, it's much more this last piece. It's much more something that really takes over your life. It's the difference between wanting to look better, which we know eating disorders are not, and wanting to be better, which we know at their core all eating disorders are. Eating disorders come from this profound sense of, I'm not good enough, I'm not worthy, I'm not deserving, and more specifically, I'm not as deserving as other people, or I'm not as good enough. I'm not as good, rather, as other people are. I'm not as worthy as other people are. And when I've asked patients this question, almost everyone I've ever worked with can tell me that from a very early age, 3, 4, 5 years old, they've carried around this feeling of understanding on some level that they're not as good as the people around them, or they feel like they have to try harder, or they have to be better in order to sort of rise up to the level of everyone else. And when that feeling is there from such an early age, it really profoundly impacts on your whole worldview, and then starts to impact on how you manage the increasing anxiety that comes up from those kinds of really, really difficult and ultimately painful feelings.
that's so spot on. Like, I love how you called that out, because I think that is just really, this core worth is such an important part of just being enough of recovery.
Yeah. The opposite, so, I just had a baby, and, well, to be fair, I didn't have the baby. My wife had the baby, but we have a newborn. And especially now that I have this really clear, salient example of like a creature that I'm kind of responsible for, I'm very aware of the importance of making sure that he feels like he is the center of the universe, right? That is such an important developmental thing for all of us to have experienced early on in our development, that we are the best thing since sliced bread. That's a really core human need that all of us have. And when, for various reasons, that process, that really important developmental process, gets interrupted, whether it's an external reason that it might get interrupted, or for some people it's just kind of an internal reason that gets interrupted, it really has long-lasting effects throughout all of our later development.
Mm-hmm.
So if eating disorders aren't just disorders of wanting to look a particular way, then what are they? I think in the spirit of what we're talking about, it makes much more sense to think about eating disorders as disorders of disconnection, disorders of shame, disorders of anxiety. Jess, you asked me at the beginning, sort of what are some of these things that underlie, that go across all eating disorders, and this is what goes across all eating disorders. Forget about any of the forgetting about anything too technical. At the most basic level, everyone who's struggling with an eating disorder is struggling with a profound sense of disconnection, is struggling with a lot of significant shame, and is struggling with really profound anxiety.
Totally.
And disconnection operates on a number of levels, right? It's disconnection, certainly in terms of relationships. This doesn't mean that people with eating disorders aren't in relationships or can't have relationships, obviously. But when you're struggling with that really, with that longstanding feeling of I'm not good enough, it's going to impact on how honest you feel like you can be, or how vulnerable you feel like you can be. And without honesty and vulnerability, it's really difficult for any of us to maintain healthy reciprocal relationships with people. It disconnects you from the full experience of existence. There's this really wonderful growing body of literature on happiness and on positive psychology. And study after study shows that among the most common characteristics of people who are kind of generally happy people is a clear sense of purpose and meaning. If you don't have a sense of purpose and meaning, it's very, very difficult to just kind of exist. We really need that. It's as basic of a need as we have as a species. And that's one of the things that I think is in many ways the most painful thing about this illness, because it really robs you of that connection to something bigger than yourself, and it robs you of a connection to a larger sense of purpose or meaning, and that really makes it difficult to fully participate in just kind of being and in existing. It certainly disconnects you from yourself on a number of levels. Obviously at the level of basic sensations, you become disconnected from hunger signals, from lots of other need signals, as well as spiritual needs. The spiritual needs that we all have. It disconnects your body from your mind and your spirit. And then finally, certainly last but not least, it disconnects you from a sense of curiosity and meaning. It's very difficult to exist in a hypervigilant, threat-based state all of the time and maintain a sense of curiosity. Because if you think about it from a survival standpoint, curiosity isn't terribly important if all you're trying to do is survive. Curiosity is very different from being hypervigilant. They're really incompatible states to be in. And we need curiosity. We need wonderment. All of those are important things that lead to a sense of meaning in our lives. Especially when I talk to new therapists or when I talk to other professionals, I like to say that I feel tremendously fortunate that I found something in my work that gives me so much meaning. And I'm sure you would say the same thing. When you're existing with a clear sort of mission, and when you find a mission and find something that gives your life meaning, it really changes everything. And I can have horrible days or terrible or really difficult days, and and it's certainly, this work is certainly not easy for anybody, but it definitely provides a very clear sense of meaning and purpose, and
Very,
that's
yeah,
so important.
very meaningful work. And an interesting thing about, with eating disorders is obsession around routine
Mm,
really does take away that curiosity component, right? Because you're just so
right.
fixated on what is known or what is familiar as opposed to like what's possible with the kind of curiosity component.
Exactly. And if you start to think about what else might be possible, or wonder about what else might be possible, and you're in that kind of state, that's just going to produce more anxiety, because exactly as you're saying, that's all the unknown. That's all the very, black unknown future. Like, that's just going to increase your state of anxiety. So you're absolutely right. Um, Eating disorders are also disorders of shame. Um, all of us can understand guilt, and all of us can understand shame. Shame is actually, from an evolutionary standpoint, a very important emotion for us to have as a species, because it's a socially corrective emotion. If we do something transgressive and then we feel shame about it, most of us would feel some sense of wanting to rectify that or do something different the next time. So it's an important thing in terms of keeping us, functioning as societies. But so all of us can understand that level of shame and guilt. But then some people experience what's called the shame of existence, where shame that's usually linked to the self or to one aspect of the self is really linked in a much more global way to something that is of the whole self. That is, the actual existence of your personhood, of yourself, becomes the source of shame. And when it becomes that big, it's particularly intense. It's shame about the fact that you exist, the fact that you are. And it results in this really significant urge to hide, to conceal, to disappear, to take up as little room as possible, and then ultimately to cease to exist. Now, it's important to understand that this is not necessarily the same thing as suicidality. This is sort of it's related, but it's really a different thing. And there's an entire body of research that tells us that the same parts of our brain that get activated with physical pain get activated when we experience shame. So in a very literal sense, when we feel shame, it is painful in the same way that anything else is painful. And I think this is something that anyone who struggles with an eating disorder understands full well, how horrible and painful existing in a shame state is.
And so it's really not about like the idea around I did something bad, which you mentioned, like a transgressive
Right.
behavior and I feel shame. It's like I am bad to the core. Like, or
Exactly.
I made a
And when
mistake.
you,
I am a mistake.
right. And it's almost like when you start from the assumption that you are bad, just like you're saying, and if you do make a mistake, like I did at the beginning with the misspelling on the title slide, that just reinforces the notion. See, there's another example of how I'm just profoundly broken, and I'm just never going to be able to do anything good or right, because look what happened even when I tried to do something, good and smart. So yeah, when you're starting from that standpoint, then everything else gets filtered through that, and it just really intensifies that experience. And then finally, and the main thing I'll be talking about, is looking at eating disorders as disorders of anxiety. Um, in particular, anorexia and bulimia are both characterized by a drive for perfectionism, a certain degree of obsessive compulsiveness, neuroticism, negative emotionality, harm and pain avoidance, and generally avoidant kinds of personality traits and avoidant behaviors.
Now, how does self-care
Even
work
if you,
into, sorry, how does self-harm work into if there is harm and pain avoidance? Because I know a lot of people struggle with self-harm.
yeah,
You also mentioned suicidality earlier. Like,
sure.
how does that work in with that?
That's a really good question. So, for most people who engage in self-harm behaviors, it's it, the purpose of it is to distract yourself in some way from emotional pain or from numbness, which can be really painful, right? It's to, it's like if I have an itch on this hand, but then I don't know, if I start like scratching myself over here, it'll probably distract me at least from this itch on the other side, because I'm putting my attention to something else. That's a silly example, but that's
That's a
kind
good
of what
example,
most
yeah.
it's kind of what many people who struggle with self-harm urges do talk about. If you have, I think any of us would rather have physical pain than emotional pain, right? Emotional pain, that's something you would really never choose. And if you had the choice, or if you felt like that was the only choice you had, then in a certain way, it makes a lot of sense. So it's still driven by avoidance. It's avoiding the much more painful the much more painful emotional pain, and you're just using some other, you're using physical pain to try to help yourself distract from that.
Yeah, great response. It's like the emotional pain's more buried in like the surface pain, like that can be distracting. Yeah, that's interesting.
Yeah. Yeah, I mean, it's more varied, it's more painful, but it's also more confusing. It feels much more overwhelming. Feels like something you can't do anything about, whereas, something physical, you certainly. Um, so even when we look at some of the differences between, for example, anorexia nervosa and bulimia nervosa, most people think about anorexia as being characterized by high levels of constraint as opposed to impulsivity in bulimia, constricted affect as opposed to emotional dysregulation in bulimia, rigidity versus sensation seeking, anhedonia, and asceticism versus affective extremes and lability. What you can see with those characteristics that appear to be opposites is that it's really the same thing. It's just different degrees of the same characteristic. And really what all this is telling us is that there's much more commonality between those two than there are differences.
There's some clinical terms in here that I want to kind of get at a little more. So what's emotional dysregulation for someone who hasn't heard that term?
Emotional dysregulation can look like a number of different things, but it can look like either having a particularly strong emotional reaction to something, or it can also look like um, having a really muted emotional reaction to something. It just means, it's sort of what it sounds like, that you're somebody who has a hard time regulating your own emotional states or regulating your own emotional responses to things.
Because there's like big shifts in like emotional states, would you say, or it's
Yeah,
a harder time?
big shifts, rapid shifts, more intense shifts, all of those. Yeah.
And then for the constricted affect and mood expression, what is that? How does that kind of differentiate from emotional dysregulation?
Sure. So constricted affect means then it's a little bit kind of the opposite as we're talking about. It's somebody who has very sort of muted or blunted or really no emotional reactions to things. Now, presumably they are having kind of an internal emotional reaction, but there's no real expression of it. So that they're not really reacting to things that maybe they ought to have some kind of reaction to. And internally, what it feels like is kind of it's that like numbness and that feeling like nothing sort of produces strong emotions in either direction, and that's really the one of the more difficult things is that when if you're somebody who's used to feeling a lot of anxiety, for example, or a lot of sadness or a lot of any other kind of emotional pain, not feeling anything actually feels kind of good, right? Because when emotions start to feel really overwhelming, then not feeling anything is actually a bit of a relief. The problem is it also means you don't feel good things. You don't feel happiness. You don't feel you don't feel love. You don't feel affection. You don't feel excitement. Those are all things that we really need, all the full range of emotional experiences, just as human beings. So constricted affect affects all of that. It means you don't feel a lot of sadness, but you also don't feel really intense happiness about things either.
So there's kind of that trade-off. Now, I've never heard this word, and anhedonia, and how do you?
Anhedonia.
Anhedonia, what is
So
that? Sounds like a
Anhedonia,
region of like the Shire.
right? A beautiful island off the coast of Greece or something. Anhedonia just means that you don't experience pleasure in things that would normally give you pleasure. It's the lack of think about the word hedonism, which is Greek. If you're a hedonist, it means you sort of live for all of the things that give you pleasure. So anhedonia would just mean the opposite, that you don't you're not able to feel pleasure in things that normally would give you pleasure. If you're somebody who loves music and all of a sudden you find that music no longer gives you pleasure, you can imagine that would be really distressing.
Mm-hmm.
So people who are really depressed often experience not being able to find pleasure in things that normally would give them some amount of joy.
And so for bulimia nervosa, on the other hand, this affective extremes and lability, that is kind of that hedonism, like you're saying, like, or is that similar?
Yeah. No, it would be sort of the feeling things a little too strongly or a little bit too intensely, and then those feelings changing, rapidly from one state to another.
And where does binge eating fall in here? Would you say a little bit more to the side of the bulimia nervosa?
Yeah, so binge eating is complicated because first of all, it's a new diagnostic entity, and it's the category or the diagnosis that we really know in many ways that we really know the least about, and we don't know that much, to be honest, about either anorexia or bulimia either. But even relative to that, we know even less about bulimia nervosa. I'm sorry, about binge eating disorder. So it's hard to say. It's hard to say where people with binge eating disorder fall on the spectrum. I think, in a more general sense, most people that I've worked with binge eating disorder would have more in common than they don't have in common with anybody who's struggling with an eating disorder. That is, that there's more commonality among the three of them than there is differences. There certainly are differences, and there's lots of good reason for treatment to look different for somebody with binge eating disorder, even for the psychological pieces. But at their core, I think, as far as my clinical experience goes, at their core, people are struggling really with the same kinds of core issues, especially if we come out to the level that we're really talking about here, at the level of shame. That absolutely is something that exists in binge eating disorder. It might look slightly different, but really it looks different from person to person anyway. But there's no doubt that people with binge eating disorder struggle with tremendous feelings of shame. There's a lot of anxiety and fear that goes along with binge eating disorder, and it also serves to isolate you and disconnect you from people.
Yeah, great answer. It just goes to show how multidimensional eating disorders really are.
Yeah. So here's another way to think about how all of this might play out, or how all of this might manifest. So taking this idea of an anxiety-based model of eating disorders, a transdiagnostic model of eating disorders that might apply to anyone struggling with any of the eating disorders. It might look something like this. You have somebody, as we've talked about, who for any number of reasons is just temperamentally somebody who's prone to extreme sensitivity. And if you think about sensitivity, and even just sort of what we mean by somebody who's sensitive, it's got both connotations, right? It's got the connotation of somebody who is sensitive to other people, who's empathic, but it also has the meaning of you're sensitive, as in maybe you're somebody who gets your feelings hurt a little bit more easily. And I think those are those kind of come with, those are two sides of the same coin. So if you're somebody who's just somebody who's more sensitive, you're going to experience both of those things. So if you're somebody who, for whatever reason, just is constitutionally or temperamentally sensitive person, it's going to result in a certain level of impairment in your ability to modulate your own emotional response. And you're going to tend to experience emotions and situations subjectively as much more aversive than other people, right? So you're more sensitive, and if you're more sensitive, it's more difficult to really modulate your emotional responses to things that happen to you and things that you experience. And so everything is going to feel a little bit more intense, a little bit more aversive. And that includes positive experiences, by the way. That feeling intense positive emotion can feel just as aversive to some people as negative ones. As a natural response, anytime we as a species feel and actually any species really, that we feel something aversive, our natural response is to not feel that, do whatever we need to do to not feel that. If I touch something hot, I'm going to move my hand away because that's an aversive sensation, and my brain tells me move your hand because you don't want to keep feeling that. So it's a very natural response to anything aversive. Psychologically, what that might result in is frequent attempts to try to control, suppress, distract, any kind of avoidance strategies to not feel that aversive thing. So over time, one tends to then over-rely on strategies like worrying, obsession, compulsive behaviors, sometimes including self-harm, any number of avoidant or distracting kind of behaviors. And this really is a cycle. The more you engage in those kinds of behaviors, the more sensitive you become. The more sensitive you become, the more difficult it is to modulate your own emotional response. And then the more things feel aversive to you, the greater the drive you feel to try to suppress those anything that's aversive or avoid aversive situations or aversive feelings. And that just gets stronger and stronger and stronger. This is really very much the cycle that so many people struggling with somas are stuck in. It's, the behaviors really tend to reinforce the sensitivity, reinforce the negative feelings, and reinforce the aversiveness. But unfortunately, what happens is that just drives the urge to engage in behaviors even more. At a more sort of epidemiologic level, or just kind of a more diagnostic level, we do see a lot of overlap of anxiety and eating disorders. So it's both overlap in terms of anxiety as a bigger construct, but also anxiety as in anxiety disorders. Certainly, we see avoidance of feared foods that is indicative of anxiety. We see ritualistic and compulsive behaviors that are indicative of anxiety, somatic symptoms that are in common with anxiety disorders. There's this overvaluation of an irrational belief system that has dysfunctional behaviors associated with it. But we also know that even after things like weight restoration, even after people's eating disorder behaviors have really stopped, that really a lot of anxiety symptoms tend to persist well after that. So in other words, all of your specific eating disorder behaviors might actually be gone. But what for many people, if not for most people, what's really left over is anxiety. And that's the thing that really takes the longest to go away over time. A significant portion, more than half of patients with eating disorders, have at least one anxiety disorder diagnosis, primarily obsessive compulsive disorder, social phobia, but also generalized anxiety disorder and other of the anxiety disorders. We also know that anxiety symptoms in anxiety disorders tend to precede eating disorder diagnosis. That is, symptoms of anxiety, indications of anxiety tend to be there before eating disorder behaviors start. So typically when we ask patients, for example, at what age did you first start engaging in dieting or restricting behavior or exercising to the point of, pain or fatigue, purging behaviors, etc., the answers might be 13, 14. When we ask the follow-up question of at what age can you first remember feeling like there's something really wrong with me? I don't belong, I don't fit, I don't work in my family, in my community, among my friends, I'm not as good, all of that stuff we were talking about. And almost every patient I've ever asked that question of will answer, oh gosh, 3, 4, 5 years old. That's anxiety. That's anxiety that's there well before, whatever eating disorder behaviors might later manifest are going to come along.
So can anxiety actually go away or lessen? So for someone who hears this, okay, I'm going to let go of the eating disorder and then my anxiety is going to still be there. What have you seen clinically for people to get to that point where they're able to effectively, is it about just managing your anxiety or does it go away entirely?
So that's a complicated question. I mean, from From a clinical standpoint, absolutely. Anxiety can be more than managed. I mean, I think managed kind of sounds like you're going to always have to live with some kind of, some kind of impairment or something. But anxiety really can be effectively managed in a number of ways. Specifically, in terms of talking about folks who are struggling with eating disorders, absolutely they can get their anxiety under control. The only reason I'm hedging a little bit on the answer is because we never want to get rid of anxiety completely, right? Anxiety is helpful. Anxiety helps us study a little bit longer for that test that we have tomorrow. That's important. Anxiety makes us look up directions for a meeting we have that's really important, and we want to make sure we know where we're going and how long it's going to take. Anxiety is super useful. Anxiety is what allowed our ancestors to survive. Those caveman ancestors who weren't anxious, who weren't hypervigilant, didn't survive. They were the ones who got eaten because they weren't anxious enough. So it's really inborn in all of us to not just experience anxiety, but to have a little bit of it. And obviously, some people have more of it than others. But it's not good to have no anxiety either. So it's finding that balance to where it's not impairing your ability to engage in life, and still is maybe there to a helpful degree. So, yes, from a clinical standpoint, absolutely, anxiety is something we actually know pretty well how to treat, and it's something that does go away over time.
It's a really hopeful point you made. I like it.
Yes, yeah, I know it sounds super hopeless. It sounded super hopeless before, and I certainly don't mean to give that impression. When we talk about recovery is absolutely possible, and many people do fully recover from an eating disorder. Part of what we mean by that includes what I'm talking about. Functionally, if somebody is just simply not engaging in behaviors anymore, that's not really recovery, because there's going to be other things. If there's still a really high degree of anxiety there's still going to be some kind of impairment. When we talk about, you can absolutely recover from an eating disorder, we're including all of this as well. It just might be the last pieces that most people have to deal with in the course of their recovery. I think another way to think about the overlap is to look at eating disorders as overexpressions of fear-based learning. So, and the reason why, at least to me, this is an important thing to think about is that, like I was giving the example earlier, fear is really good. Fear is essential for survival. We have fear because our ancestors had fear, because that's what allowed them to survive. So I think it's also important to recognize the positive value of anxiety symptoms and the positive value of fear. It gives us important signals about the world. But what it does seem like is that eating disorders might reflect some kind of overexpression of fear learning in those individuals who struggle with eating disorders. What does that mean? That means that you might be more prone to making fear associations than other people are. You're just more likely to attribute or to attach fear to situations than other people might be. And then once you start attaching fear to something, then all of those really old primitive mechanisms in our brains kind of kick in, and that's what becomes, and it really takes over. When fear is when we experience fear, that part of our brain really takes over, and our frontal lobe, our thinking part of our brain, really kind of shuts off. It's also important to understand, because the other implication of somebody who might be overexpressing this kind of fear-based learning is that it also makes it difficult to learn new behaviors, because you get really stuck in rigid, ritualized patterns of behavior. And it's if you want to put it this way, if it's part of your wiring to be more fear-based, it's also going to mean that it's just more difficult to learn new behaviors and to change old behaviors. So I know a lot of people get so hopeless in treatment because they want to get better, they want to change, and yet they find themselves really having a lot of difficulty changing their patterns. Well, there's a good reason why. It's not lack of effort, it's not lack of motivation, it's not lack of good enough willpower or any of that. It's just a part of, unfortunately, part of the way that you probably process a lot of information, and it just makes it difficult to change really fear-based behaviors. Again, that's a really, if that weren't the case for all of us, we wouldn't survive. Our ancestors rather wouldn't have survived in the when there was a lot of danger in the environment. So, in summary, what does it mean to think about eating disorders as anxiety disorders? Well, we certainly see a significant level of comorbidity of anxiety and eating disorders. There's also something I didn't talk about before, but there's a lot of what we call cross-heritability. So not only are for example, family members of somebody with an eating disorder much more likely to have an eating disorder themselves. In other words, there's a lot of genetic vulnerability and genetic inheritance patterns to eating disorders. But that same pattern holds true for anxiety. So first-degree relatives of those people with eating disorders are not only more likely to have an eating disorder, they're also more likely to have an anxiety disorder. And that's a relationship that doesn't necessarily exist with something like depression or any other kind of psychiatric illness. We can see that the core transdiagnostic features are anxiety-based, as we've been talking about. And if you look at the core compensatory behaviors that exist in eating disorders, whether it's excessive exercise or purging or any kind of avoidant behaviors, they're really safety behaviors, just like in OCD. They're behaviors that are designed to provide some sense of safety in that particular moment when you're starting to feel an increase of anxiety coming up because of whatever the situation is. And then finally, there's this strong propensity for fear-based learning and responses. So I think once you start to understand all of this, then it actually is quite helpful. Then it means you can start attacking it from the standpoint of anxiety disorders and from the standpoint of what we understand about anxiety disorders. If eating disorders are anxiety disorders, then that's actually very helpful for us to understand, because it tells us a lot about what might be the really effective treatments. That is, treatments that work for anxiety then ought to, or approaches, at least in theory, that work for anxiety are at least a good place to start when it comes to treating eating disorders. And the basis of treatment for any kind of anxiety disorder on one level or another is exposure, whether it's a phobia, whether it's generalized anxiety disorder, whether it's PTSD, or whether it's obsessive compulsive disorder. At a basic level, with any kind of anxiety, the main thing that you do is exposure. The way that exposures might look is going to be a little bit different depending on what you're treating, but that's basically what you would do for any kind of anxiety. I'm going to talk about exposure and response prevention specifically because it's something that we think is particularly relevant and useful in eating disorders for a number of reasons. Exposure and response prevention comes from OCD treatment. Exposure and response prevention is based in learning theory and behavioral psychology, and it's predicated on learning through experience that feared consequences don't occur. OCD, when it was first being described clinically, was really thought to be untreatable because we tried to do any number of exposure approaches and nothing really seemed to work. It's a very if any of you have experience with it personally or have a relative or somebody who has OCD, it can be really intense and it can be quite difficult to treat. So it wasn't until someone paired doing exposures along with response prevention that they found an approach that not only seemed to work, but worked extraordinarily well, to the point where it is the gold standard treatment for OCD. There really is nothing else you do with OCD other than exposure response prevention. It's more effective than medication alone. It's more effective certainly than any other kind of intervention. So it's quite unique in that way. And there's lots of elements of it that are very relevant to eating disorder treatment. So basically what you're doing is you're learning a no fear signal, that the danger is over and that there's no need for me to engage the fear parts of my brain. And the way that we start exposure and response prevention is you present the rationale that we all tend to reduce discomfort through escape or avoidance. So that's a very normal thing and a normal impulse that all of us engage in. But at some point, when avoidance stops working, we might develop compensatory behaviors as well. Unfortunately, what happens is then that strengthens the association um, that you need to engage in the compensatory behavior over and over again, and it increases the chance that you're going to continue to do that in the future. Right. So what's happening is that it's reinforcing this belief system that using avoidance and using compensatory behavior is going to be necessary, will always be necessary, and may even cause you to lose your mind if you stop doing it. That's very much what people with OCD describe, and I think that's very much what a lot of people with eating disorders also experience. That if I don't purge, if I don't restrict, if I don't engage in whatever my behaviors are, then my anxiety or whatever the painful feelings are that are inside are just going to continue to build and build and build and build. And if I don't do my behaviors, I'm just going to lose my mind. We do general education about escape or avoidance, that it reduces anxiety in the short term but increases anxiety in the long term. And that repetition of these behaviors results in increasing level of cognitive distortions. And then we introduce the various elements. So there's the actual exposure itself. In vivo exposure is what we call any kind of exposure that is a direct contact with whatever the feared stimulus is. And the purpose of that is to help you habituate to anxiety. It's the natural way, actually, that we all learn to reduce fears. It's how we learn to do any number of dangerous things, like riding a bike. That's how we learn how to swim or drive a car. You've got to basically get over the anxiety that's present because you're doing something that could potentially, hurt you, and you need to do it. And if you fall off your bike, you need to get back on the bike and keep going, etc. So it's a natural way we all learn how to do any number of things. But it's something that for some people can be very difficult to try to think about. But it's extremely important to habituate to anxiety. We present this idea of a subjective units of discomfort or distress scale, SUD scale, and it's basically a simple anxiety rating. It can be 1 to 100, 0 to 100, 1 to 10, 0 to 10. It's just a simple anxiety rating of no anxiety all the way up to the most anxiety you could imagine. And as you're doing the exposure, then you would rate your anxiety at various points. What's your anxiety before the exposure? What's your anxiety once you start the exposure? And then what's your anxiety level as you go through the exposure itself? Before we do that, we set up a hierarchy of feared situations or feared stimuli in order of how much distress it causes you. Now, if you don't have access to the stimulus live for some reason, you can also do imaginal exposures. That is just imagining in detail the distressing thought or situation. And imaginal exposures actually are very, very powerful. They can create a very, very strong degree of discomfort, especially if you're someone who has a true sort of anxiety or fear based association with something. And it can be just as effective as in vivo exposures, especially because you don't always have the opportunity to do in vivo exposures.
Would an example
and then
of
finally,
an exposure, would an example of an exposure, or an example of an exposure, would that be like, having a challenge food, like having a food that you think is, your biggest fear food? Would that be like an exposure you get in a clinical setting, or like not exercising one day, if that's your behavior?
Yeah. So let's take a simple example. Let's say your biggest fear food is pasta, right? So we're not going to just put a plate of pasta in front of you on day one, but we would build up the exposure. But at some point, when you get to that point in your hierarchy, then we would structure the exposure, and maybe it's the first step is just having it in front of you, and if that's something that's going to cause you anxiety, and then maybe the second step would be and then doing the exposure with just the plate of pasta in front of you. And then at some point, you're going to have to eat some of it. And then at some point, you're probably going to have to eat a portion, an actual sort of normal portion of it. And then presumably at some point, we would integrate it into a meal so that it's being done in a more naturalistic setting. So, we do food exposures all the time. I mean, anybody who's had eating disorder treatment, any nutritional thing you're doing is probably a food exposure. Whatever foods you typically avoid, your treatment team is going to probably recommend that you at least expose yourself to it. It gets more complicated when it's situations. So for some people, I'll give you an example. Eating in front of somebody is particularly anxiety provoking. All right, so there's the social element of somebody, and the fear might be that they're judging what you're eating, or they're judging you because of what you're eating, etc. So we would structure that exposure a little bit differently, because it's not just about the eating part. There's also the social element. So you would break it down into different permutations of that situation, and see what would be an easy place to start, and then gradually work your way up to a higher level of exposure. Where it gets really complicated is, for example, when somebody has a lot of trauma that's either directly associated with food, that is, if they've experienced abuse where food or something like that was involved, which is unfortunately common. Then we have to structure a lot of it, a little bit differently, to take into account that there's also this traumatic piece that's attached to it. Just being around other people for some people is an exposure. Just sort of being vulnerable and trying to show your true self to other people can be an exposure. There are any number of things that you can design to be an exposure, but you start with some understanding of what somebody is fearful of, and then what the associated behaviors are.
It's fascinating. And the hierarchy, I find, is the most fascinating part, because it's like you can kind of tiptoe into it, or like, when you get into a cold pool, you often like put your foot in and then just slowly dip in until you're immersed, and it's not that bad once you're in there. Right. But at first it was a little bit like, whoo, it was a little intense.
Yeah, no, that's a great example. Again, it shows you sort of the this is a very normal thing that we all kind of intuitively understand. If you think about somebody who might have like a driving phobia or something, exactly as you described with dipping your toe in the water, it might be just sitting in the car in the driver's seat, and then it might be turning the car on, and then it might at some point be driving down the driveway a little bit, and then eventually you've got to like get on the highway or something. But yeah, intuitively we all understand that's a good way to easier way into something that has a little bit of aversiveness attached to it.
And when you do the hierarchy of fears, are you also looking at what the like irrational thought can be around it? Like, so just, or like what would happen if this was in front of you? So people can kind of start to see that. Is that part of the process, is to like put out what you think is going to happen versus what happens?
Exactly. You want to understand. You want to understand what's associated with this particular situation for that particular person. So you can imagine everyone's hierarchy is going to look completely different. Even if it might involve a lot of the same elements, the order in which the hierarchy, the different elements might be in the hierarchy is going to be different from person to person, because each of those things have different associations for different people. So you absolutely need to find out what's the emotion that's evoked when they think about it, how much emotion or anxiety is evoked when they think about it, and what other thoughts or what's the belief that's involved in thinking about it, or in when they think about exposing themselves to something. Because it's not just going to be, for example, it's not just I'm going to gain weight, right? If we think about fear foods, that's probably there. But it's not just that. It's also going to be many, many other things, many more complicated, deeply rooted things that are going to be associated with it that's really driving the fear. So it's absolutely crucial to understand all of those associations, because it's not something you're just going to be able to guess at. And then the final piece is the response prevention piece. So you are put in front of the situation that normally causes you anxiety. And then what's the most important element is that you're not allowed to engage in your typical compensatory behavior. to alleviate your anxiety. You've got to sit there with the anxiety and monitor it and allow it to happen, because you need to learn that no matter what, at some point anxiety is going to plateau, and then at some point, even if you do nothing about it, anxiety is always going to go away. It's just the way that our nerves are. Are designed. They can't just keep firing indefinitely. At some point, they have to fatigue. But what happens if you are somebody who's used to engaging in compensatory behavior is you start to feel anxiety go up, and then you do your behavior. And then the next time anxiety goes up, you do your behavior. So what have you experienced? All you've ever experienced is that anxiety just goes up. You've never experienced the plateau, and you don't experience that. Ultimately, without you doing anything, anxiety goes down. So that's the purpose, in many ways, of the response prevention. You're generating anxiety in order to break the association with fear and with the person engaging in that response. I think you gave an example a little while ago of like exercise. For a lot of people, exercise is compensatory behavior, right? You eat something, you feel guilty or shameful about it, and you have to then exercise to get rid of those calories. So, for maybe the exposure response prevention thing is you expose yourself to the food thing, and then the response prevention is you can't exercise. Again, that happens naturally in programs because it's at least more difficult to purge, so you can't really purge in program. You can't engage in other kinds of avoidant behaviors in program. So on that level, that's always a part of eating disorder treatment. But then you could also structure it in a much more, you can also do it in a more structured way like this. How all of this works is that over time and through the exposure, you learn that anxiety or the distress or the urge doesn't last forever. It's eventually going to decrease without you engaging in any kind of behavior. And most importantly, that whatever the feared consequence is, the big feared consequence does not occur. And I was mentioning this a little while ago, but you can do it in the examples that we've been giving, but you can also establish group work as an exposure to things like being vulnerable, allowing others to witness you being a genuine you, practicing appropriate limit setting or boundary setting, assertiveness. These are all things that many, many folks with eating disorders have a lot of difficulty with. And then going along with that, the being in treatment, one of the values of being in treatment is it can also be a really powerful exposure to positive emotions. Many people are just as avoidant of positive situations as they are of negative ones. So it can be particularly difficult when shame is the core of what your pain is about. But to allow other people to express positive emotions to you and for you to feel positive emotions in return is also at that level an exposure. So hopefully that gives you a sense of at least a framework for thinking about the implications of looking at eating disorders as anxiety disorders, and why exposure response prevention in particular is a particularly relevant and useful kind of approach.
Just this talk has deepened my knowledge of the shame, the disconnection, the anxiety. It's all there. I love listening to you speak on this topic. I find it so
Oh, thank you.
No, it really is. Thank you. Once again, just it's really helpful, I think, for people to see this anxiety piece. I know so much of my story was seeing this, I'm stressed, I'm overwhelmed, I'm busy, I'm not doing enough, I can't keep up, like all of this, I'm drowning, all of these like emotions or ways I described it was all anxiety. And once that label was able to really sink in, it made a huge difference in my treatment and in managing my day-to-day life now, and understanding when it comes up. And this exposure and response prevention is just really an amazing way of treating people with eating disorders. And I love that you guys make that part of your program, that reason.
Yeah, we've seen it make a really tremendous difference for a lot of people, just like you're describing, who've kind of lived with this kind of anxiety for such a long time. And when you've lived with it for so long, it's really hard to take a step back and try to look at it objectively. So, on the one hand, like labels, I think unfortunately can be stigmatizing, and we have all sorts of associations with them. But on the other hand, if it's something that can help you put a framework on something and help you understand and give you structure to help you understand what might be happening for you, then I think it can be tremendously empowering and normalizing. And especially something like anxiety. Especially when I talk to parents sometimes, and when somebody who's struggling might feel like, just my family is never going to understand what I'm going through, and oftentimes it's like, yeah, the eating disorder specific pieces, if you haven't had first person experience with that, it can be really difficult to understand. But if you can describe it in the context of anxiety and insecurity and feelings, how you feel about yourself and these beliefs that you've carried around with you, those are things that I would imagine any of us can understand. We all understand the need for connection, right? We all understand shame, and we all understand anxiety. So that can also be the way to help convey in a way that that other people can understand better what you're going through, as well as to help you understand it for yourself.
Yeah, and I think that's what I resonate most with your work is this human component to it. It's not like, oh, you're just this specimen, you have an eating disorder, you're just this diagnosis, and that's it. It's like there's a human at the core of this,
Yeah.
and it's about treating that human to like really get to this place of wholehearted living and wholeness. And I love that. I think why I resonate so much with the way you teach eating disorders and educate people on it. So thank you again for being part of Recover Strong and sharing your knowledge and wisdom and insight with us today. It's been a true pleasure.
Oh, thank you. It's been a pleasure for me as well, and a real honor to be a part of all of this. So I feel really fortunate to have you as a friend, and I feel really fortunate to have you as a colleague. And I think just what you're doing is really tremendous and very important and necessary.
Agreed. Like sees like. I love it.
That's right.
Thank you. Dr. Norman Kim. All right. Thank you so much.